Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing you another really fascinating guest today involved in creating a better tomorrow for so many people. Today, we have the honor of being joined by Dr. Anna Laura Ross, who is Unit Head for Emerging Technologies, Research Prioritization, and Support in the World Health Organization's Science Division located in Geneva. She also serves as the head of the WHO Science Council Secretariat. Previously at the World Health Organization, Dr. Ross served as Strategy Technical Manager at Unitaid, their global health initiative that works with partners to bring about innovations to prevent, diagnose, and treat major diseases in low and middle income countries, with an emphasis there on tuberculosis, malaria, and HIV, as well as its deadly co-infections, ultimately providing strategic and technical support for Unitaid's strategy, working to identify priority areas to intervene for intervention, accelerate innovation for global public health. Dr. Ross has over 15 years of experience in global health, and her areas of interest have been quite broad in the area of HIV biomedical research, scientific program coordination, implementation research, and global health policy. Prior to joining the WHO, Dr. Ross served as head of international affairs and scientific relations at the National Agency for Research on AIDS and Viral Hepatitis, ANRS, in Paris, France. And previous to that, Dr. Ross carried out biomedical research at the UK Medical Research Council in London, as well as at Institut Pasteur. In this later role, she worked in both France, Cameroon, and Cambodia on the prevention of mother-to-child transmission of HIV, which was a focus of her postdoctoral work. Dr. Ross is particularly interested in facilitating and accelerating the translation of evidence-based science into policies for the benefit of global health. She holds her PhD in biomedical research from University of Cambridge, as well as postgraduate qualification in global health policy from London School of Hygiene and Tropical Medicine, postdoc at Institut Pasteur. We're honored to have her with us today. Dr. Anna Laura Ross, thank you so much for taking the time to come on the show.
Thank you very much, Ira. It's a pleasure to be here.
It's wonderful to have you. I would really like to start off just for a couple of minutes by handing you the floor to talk just a little bit more about you and your background, and a little bit about what brought you into this fascinating area of biomedical research, of course, the domain of mother-to-child transmission of HIV per your postdoc, and of course your interest in global health policy.
Thank you, and thanks a lot for the introduction as well. And it was interesting actually to hear you recount a little bit the career from that perspective as well. So thinking back, my in terms of origin, so I'm Italian originally. I grew up in a quite multicultural and international family. Most of the people actually come from more literature and not necessarily scientific backgrounds. So I was a little bit the odd one out in that sense, but I think my interest in science and the link between science and health was clear from a relatively young age, and I quite quickly identified that I wanted to work in that general area, or that interface between biology and health, and that became more precise as I moved on with my career. So I initially, my PhD was a little bit on the interface between molecular biology and immunology. So it was quite basic, fundamental research, which I enjoyed immensely. And it's really thinking about how some of the molecular pathways work within its individual cell. But I did feel that I was missing a little bit that interaction. Well, what is the actual significance and the link with health? And I moved into that area when I started working on the interaction between host and pathogen. And this is when really I started focusing my research and my interest in understanding the mechanisms between the host, the human in this case, and the pathogen, which was in my case, HIV. And in particular, what I was trying to understand at the time was the molecular mechanisms underlying the transmission in utero, so during pregnancy, of HIV from an HIV positive mother to the unborn child at the time. So really, it was quite specific. And again, looking at the molecular mechanisms and how different cells in the placenta could be infected more or less easily. And what is obviously interesting in these type of studies is understanding, well, what makes it more difficult for HIV as a virus to infect certain cells in the placenta, and could they give us clues to help prevention of HIV infection more broadly? And so this was, you were recounting, I was at the Institut Pasteur, so I was initially based in Paris. I was actually working with Françoise Barré-Sinoussi, who then went on later to become a Nobel Prize laureate for her co-discovery of the HIV virus. I also worked in the network of Institut Pasteur. So the Institut Pasteur, based in Paris, has a network of institutes around the world. And so my first time really working and living outside Europe was in Yaoundé in Cameroon. And that was a very eye-opening experience. I was working with the Centre Pasteur Cameroun, and I was working closely with the maternity of the central hospital nearby. And I think that was the eye-opening when I realized that there was a lot of scientific evidence on how to prevent mother-to-child transmission of HIV, but at the time it still wasn't being deployed and implemented very effectively. So I saw immediately that there was a gap between the scientific evidence base that we as a scientific community collectively had identified and accumulated, and the gap between the translation of that knowledge, that evidence base, into something that actually was going to make a difference. And so I think that here is when I initially started to think about, as much as I like doing the research myself and being in the lab or doing the translational work with the clinic, that there was obviously a key piece that needed to be solved to make sure that the results coming from science, a bit more upstream, were being translated. So from then I moved on. I got to also do some research in Phnom Penh, in Cambodia. And again, this was really very rich experiences that led me to understand some of the complexities between seeing and understanding something in theory, or at least in the lab, or in a very controlled setting of a clinical trial, and what actually happens in contexts where HIV was more prevalent. So that was, I think, some of these experiences really started to I think in me, I started to realize how I probably wasn't going to spend the rest of my life in the laboratory. It wasn't quite clear how or where I was going. At the time, I still hadn't identified necessarily that I wanted to go to the World Health Organization, but I did experience when I was living and working in countries how much the ministries and the policymakers in country would be looking to the normative guidance of the World Health Organization. So clearly I was starting to understand that the countries, even if a scientist comes in and kind of hypothetically would say, well, we have these results, you know, we know that we can prevent mother-to-child transmission of HIV, there would still be that desire and the need to wait for the World Health Organization to come out with some guidelines. And this was certainly the case at the time. And then as you indicated, I started slowly to transition from doing the research myself to thinking about how we can coordinate research, trying to foster partnerships, thinking about how we could probably achieve more and think about the design of clinical trials in a smarter way and how maybe collaborating could be helpful and efficient and effective and an effective use of resources. So this was my position at the ANRS, which is the National French Research Agency for Research on HIV and Viral Hepatitis. And this is where I assumed a role as head of the of international affairs and scientific relations. And so typically I was thinking about, well, what collaboration could we do with institutes at the NIH, for example? Other types of research entities, how can we come together? And the NRS, which I think as a research organization has funded some really exceptional research, but obviously is not a huge research organization and has limited funds. And clearly there is a case of being able to achieve more when different organizations come together. And so that was just the steps prior to joining the WHO, but maybe I'll pause there for a moment.
No, that's a, you know, it's a fascinating journey, and it's a great place to pause because you know, I took time, and you know, you've published extensively on many of these topics, and it's actually when I first started swimming through some of your materials in the peer-reviewed literature, I came to this interesting point in 2016, 2017, when you were with ANRS, and you published a series of papers that are really quite sort of timely for sort of where we are almost in 2023. One was this really interesting paper in the Journal of Virus Eradication, Converging Roads, the latest science from the 2017 International AIDS Society Curing Cancer Forum. And in this paper, you know, you go into sort of a lot of the high-tech interventions that are being developed sort of after the triple therapies, and you make, you know, the points that a lot of these are interesting cancer drugs that may be repurposed in HIV. And then there's other papers you were just talking about collaboration. This one was in Trends in Microbiology, again IAS towards an HIV cure, NIH, Oswaldo Cruz Foundation, Henry Jackson Foundation for Military Medicine. And here you bring in this really interesting public health theme at the same time, that if we are going to get to eradication, we got to bring in a lot of these social determinant issues, because these miracle drugs are great, but there's other things that are important in the process. Can you talk a little bit about 2016, 2017? Because I think this is a very interesting piece of your, I'll say, your journey. And I think we want to focus on it for a few minutes.
Absolutely, and it is certainly an interesting period in my career, and a very fascinating one, because at the time, so I was still at NRS, but I had a little bit of a dual hat where I was acting as a science and strategy advisor for the HIV cure initiative of the International AIDS Society. So the International AIDS Society, which is actually based here in Geneva. So this is probably actually the first, my first foray with the Geneva-based organizations was in fact with the IAS before it was with the WHO. And it was really coordinating a group of work around thinking, could it be possible to cure somebody from HIV? So sometimes we talk about HIV eradication, or sometimes we talk about HIV remission increasingly. The general idea would be, how could we elicit a situation in which somebody who is HIV positive actually is either completely eradicated, so we have no detection whatsoever of HIV in their system, or more realistically has completely controlled HIV. So HIV is actually very, very controlled. So it's completely undetectable and remains undetectable even in the absence of highly active antiretroviral treatment. And so there was, at the time, a little bit earlier than 2016, there was an increasing movement of people and researchers around the world thinking about how could this be possible. And this was because there were a couple of, in fact, at the beginning, it was one mediatized case, the Berlin patient, so-called Berlin patient, where there was, due to a different unrelated condition, there was a stem cell transplantation, which led actually to the eradication, the first case of HIV cure. And that obviously got a lot of brilliant minds thinking about clearly the type of intervention and the type of therapy that was used in the case of the Berlin patient isn't something that was going to be replicated broadly and widespread, but it made people think that maybe there was something that was possible. Could we imagine a situation in which HIV might be controlled or eradicated in a way that people wouldn't have to be under lifelong therapy? And so this was with the context of the International AIDS Society. It's a group that, or initiative, or I would say a school of thought of research, and it continues today. There's still many ongoing research and clinical trials. Obviously today, unfortunately, we still haven't been successful to fully identify a very easy and widespread approach that would allow this, but of course, nobody expected that it would be easy or be able to reach it quickly. What I think was really interesting was that, of course, there was a lot of very upstream research happening, trying to understand some of these underlying mechanisms. So there were a group of researchers looking at HIV controllers, for example. So people who are infected with HIV, but seem to be able to control the virus into very low levels without antiretroviral therapy. So understanding some of these mechanisms. And there were also some of the clinical trials that were happening, trying to understand, again, these mechanisms and what could be possible or not. What I found fascinating is that it was really a group that brought together many, many different people, and importantly, the people living with HIV themselves. And this was, I think, extremely important because the people living with HIV actually were instrumental in telling the scientific and the research and the clinical community what was important for them in terms of what they would like to see in terms of HIV cure.
Yep.
And I remember quite vividly, there was somebody who I think their background was in communications, but they'd done a little bit of a rough and dirty survey which identified some relatively surprising answers, I think surprising from the point of view of some of the researchers, because some of the researchers were convinced that they knew what an HIV cure had to look like. So they knew this is what we need to achieve. It has to be like this. These are the characteristics, et cetera, et cetera. But actually, when we as a scientific community listened to people living with HIV, we understood that there were actually some other criteria that might be more important. So for example, not everybody living with HIV necessarily wanted to have the virus completely eradicated. Many people had built their identity around living with the virus. What was important for the vast majority of people was being able to avoid transmitting it to others. And so this was also happening in parallel to the undetectable equals untransmittable movement, which essentially now I think is quite consolidated, so that people who manage the HIV and are completely undetectable, so they respond well to treatment, they take their treatment, they do not transmit the virus to others. And I think that was also very important, so we could understand the patient point of view. Broadly speaking, I would say that actually having worked in the field of HIV, it made it very, very important to me. I understood the importance of involving the end user, the beneficiaries, so the civil society, obviously the patient-based organizations. And I think that HIV as a movement historically did very well in making sure that civil society and the people living with HIV were involved since the very beginning. And in fact, a lot of credit to them, because they managed to really move things and change policies in a very good way.
Excellent. And one of the places I'd like to go before we get to your current role at WHO, if we go forward a couple of years from where we were just talking to 2019, while at Unitaid, you were very much involved in the STAR initiative, Self-Testing Africa, Accelerating Global Access and Scale of HIV Testing. And this is another really interesting paper because, you point out in this one that it took a long time, in the sense from the early 1980s to 2013, I believe, to even get, sort of at-home consumer-based testing for HIV. And in a very short period of time after that, via the STAR initiative, you were able to really translate this much faster in many of these underserved countries of South Africa and Southern Africa. Can you just say a few words about your involvement in STAR?
So the STAR program, which was supported by Unitaid, and I think we described Unitaid in the introduction, and Unitaid, which Global Health Initiatives, so obviously really helping support the optimal access to innovations. So making sure that when an innovation exists, they can actually be adopted and scaled up in the best possible way. And in this case, obviously, we're talking about HIV testing, and specifically, we're talking about self-tests. So self-tests are tests that, as the name implied, are administered by the person or by somebody they trust, but essentially outside of the healthcare system. The project that we were supporting was really trying to say, well, there is something that exists. We know that HIV self-tests, they exist. They had been they've gone through the quality process, and we knew that people were able to use them in a reliable way, and that it was really a very helpful tool to be able to increase access to testing. Because one of the issues that we have, especially still in relatively high prevalent settings, is that not everybody necessarily will go and be tested, or they will necessarily repeatedly test themselves. And I think that the principle is quite easy to understand, that it's easier to test yourself if you can access a test easily, and you can maybe do it when you're at home or in a place where you feel comfortable, instead of necessarily having to go to a clinic, having to do it, to wait, etc. So this project really supported the access of self-tests, and in fact, it just recently, a couple of years or a few years since I moved on to my current role, but actually we've seen a decrease in the pricing of self-tests for HIV. So I think that they're available now at a $1 price. And so that's obviously also something which is an enabler to increase the access to testing. And I think that now that we've been through COVID-19, I think I felt myself reflecting on the fact that, of course, there are COVID-19 self-tests that were available in many different countries, and thinking about how experience that we had in the HIV field on how to ensure that a self-test would be used appropriately. What type of guidance? Do we need to make adjustments to the information that is included in each individual self-test? And how some of this information has actually helped possibly other fields. So we've seen this maybe with self-tests for viral hepatitis, and to a certain extent with COVID-19 as well. So that was an interesting experience, is also thinking about how can we take what we learn in certain areas and apply our knowledge to maybe different disease settings without having to reinitiate and reinvent the wheel in terms of generating all of the evidence. Of course, some evidence is specific and needs to be generated because it has specific implications for each context. But I think that was an interesting show of how a lot of what we learned I saw applied in real life during COVID-19.
Wonderful, wonderful. So the WHO creates the science division, which you're now involved in 2019. And just reading a bit from your science division of the WHO, harnesses the power of science and innovation, providing leadership and leveraging the best scientific evidence to improve health and promote health equity for all. And formed at a very opportune time, or just a little bit before COVID comes into play. talk a little bit about just why the organization was set up, a little bit about how you then made the transition from Unitaid into the new science division, and a little bit of sort of where the directives come from. I'm sure you get, as you were mentioning, someone might contact you from Cameroon or Cambodia, whatever, with decent ideas for innovation. How does it work? Let's talk a little bit through the current structure of the science division.
So you're correct in saying that the science division was essentially created in 2019, and this was the result of what we call a transformation. So in the first term of the current Director General, Dr. Tedros, one of the main results, at least in my perspective of the transformation, which is essentially organizational restructuring, was the creation of the science division. And for the first time, the World Health Organization had a chief scientist who was nominated, so Dr. Soumya Swaminathan, our chief scientist. And now, of course, it's important to remember that WHO has 7 decades or more of experience in science and research. And so the fact that the science division was created in 2019 shouldn't imply in any way that this is the first time we're thinking about science and research.
Right.
But it is the first time that we have a central division, a center of gravity, if you wish, for science and research and innovation and thinking about technologies. Now, the technical departments across the organization continue and have a very science-heavy and research-heavy activities and operations. With our unit, we really want to try and centralize and coordinate some of these activities and see if we can support them and make them more efficient and harmonize them and standardize them. So when we think about harnessing the power of science and technology, I think it's fair to say that the World Health Organization was better known for being the normative agency par excellence in global public health, but was not necessarily known as being the most forward-looking, state-of-the-art in terms of new science and technology. And this was one of the things that the current Director General, Dr. Tedros, and our Chief Scientist, Dr. Soumya Swaminathan, have highlighted that WHO needs to be ahead of the curve. We need to be proactive in thinking about science and technology and how the advances in science and technology can be best harnessed for global public health. Now, what does this mean? It means essentially that I think it's clear to most people, advances in science and technology most often will be translated to the benefit of people living in high-income countries. And often there is a gap, a time lag between when people in high-income countries can benefit from advances in science and technology and when people living in low and middle-income countries can benefit from those same advances in science and technology. And so clearly this is an equity issue, and we want to be able to promote the most equitable access to the products of scientific research and innovation. So what we do specifically in my unit is we do think about emerging technologies. And in fact, we have a program which is the Global Health Foresight function, which we coordinate in my unit, which is specifically geared up and set up to be able to scan the horizon for new advances in science and technology, identify the most promising ones that could have an impact on the most plausible ones that will have an impact on global public health. And this gives us the opportunity to sometimes think about technologies or new innovations or new discoveries that could have an impact in maybe 5, 10, or even 15 years. And although it's sometimes difficult to think that far ahead, it is very important to make sure we can start the necessary dialogues and considerations as early as possible. So this does allow us to think about what might be some of the governance frameworks that might need to be implemented so we can harness in the best way possible these advances in science and technology. Because of course, if something is ready to be used, but a country isn't set up to use it or doesn't have the right policies or doesn't have the right infrastructure, then of course there is going to be a lag, a time lag, and a gap in the access. And we can also think about maybe some ethical considerations. So one area which I can cite, which is a sister unit to the one that I lead, the unit on health ethics and governance, they issued, I think it was last year, a series of recommendations and a governance framework for human genome editing.
Yep.
Because we need to think about what are some of these ethical considerations. So by doing some of this foresight work and identifying as early as possible specific priority areas that require more attention, be it to accelerate the benefits or also to mitigate some of the risks, then this allows us to be a step ahead and to be ahead of the curve. And just maybe a quick mention on the risks side, because part of the work that we do in the unit also looks at mitigating biological risks and thinking about governing dual-use research. Now, dual-use research is a terminology which indicates generally life sciences research that is intended for peaceful purposes and in our case for the benefit of health, but that could be applied to cause harm to humans or to non-humans or to the environment. And sometimes we differentiate whether it's accidental use or unintended consequences, or sometimes even deliberate misuse that can cause risks. I put this up because I think that everybody has woken up to the concept of what a biological risk is and how impactful it can be. And unfortunately, COVID-19 has been a stark realization for many people that biological risks can happen. And that, of course, the consequences of pathogens is obviously can have a global impact. So part of the work that we do is also trying to think a little bit ahead. Now, the work that we do doesn't relate specifically and solely to pathogens, but I think we would be hard-pressed to find any single advance in technology or any new innovation that is completely without any kind of risk whatsoever. So we do look at areas as diverse as neurosciences, the application of artificial intelligence, microbiome, and really thinking about what can these new technologies afford us in terms of benefit, but let's also make sure that we're thinking of the risks and we don't forget about the risks or leave them a little bit as something which deserves less attention.
You know, it was interesting as you bring up this topic of dual use. I watched a presentation that you gave about a year ago now. This was on synthetic biology and the Convention of Biologic Diversity. And here again, you were talking about this sort of responsible innovation, right? And then because I noticed one of the things in sort of the list, you mentioned artificial intelligence, gene editing, and so forth. But another thing that's there is genetically modified mosquitoes, which obviously have tremendous potential in terms of malaria eradication and all that. At the same time, right, we're releasing an organism and so forth. And I found it very interesting that you were not just humans here, right? You're also thinking about sort of the broader issue of biodiversity. Talk a little bit about that, if you would, and a little bit of sort of the message regarding, as you were saying in this presentation, shared responsibilities with some of these really advanced tools.
Thanks. I think it's actually a really important theme, and it's one that we've been spending quite a lot of time on. So there are people within the unit who work specifically on this area, and within the promotion and raising awareness of the responsible use of life sciences. And WHO actually, we try to promote the responsible stewardship of life sciences. And this does include, as you say, very diverse subjects, including genetically modified mosquitoes, which we can see obviously could have very obvious benefits. There are a number of infectious diseases that are transmitted via the vector, which is a mosquito, but also thinking about what the consequences are. Now, what I think is interesting in this is you mentioned the shared responsibility. And I think this is actually a key phrase, and I use it more and more. In fact, I was at the G7 Global Partnership Conference on current challenges in biosecurity just 10 days ago or so in Berlin, and I was talking about this notion of shared responsibility. Today, clearly, we need to think also about the interface, what we call One Health. So the interface between human health, non-human animals, and agriculture and the environment, and thinking about how everything really fits in together and what the consequences can be and the domino effect that we can easily imagine. So when we talk about shared responsibility, there are two dimensions. One is across different stakeholder groups. The shared responsibility and thinking about promoting values and principles that should guide responsible use of life sciences needs to be done across different sectors. So, of course, the scientists themselves, this goes without saying, but I think a lot of people don't necessarily have training or even moments during their career, be it their master's or maybe their PhD, their doctorate studies, to be able to think about some of these issues, because there are very few training opportunities and training courses that happen in the context of higher education. But thinking about what might be a dual use of research, even if the vast majority of people, of course, almost everybody is working to be able to benefit global health. But we just need to raise the awareness of what potential risks it could be. So they're the scientists themselves, but also the groups who fund science, thinking about what their role might be, thinking about the role of people who publish science. So the science publishers and editors. We also see, obviously, the security sector. So people maybe who are coming from the defense sector or the military. And a very wide group of different stakeholders actually have roles in promoting the responsible use of life sciences and thinking about how this can be governed in the best way possible. And the other way to think about it is across different sectors. So really thinking about how we need to increase the multi-sectorial approach when we think about the biological risks in the One Health context.
Yep.
So I would say over the past 1.5 to 2 years, I've increasingly been in collaboration, in contact, in discussion with colleagues in different organizations, either from the UN or not, but including, for example, the World Organization for Animal Health, or obviously you cited the Convention for Biological Diversity. So really trying to think, how can we each come in with our different angles and promote something that will be really taking into considerations the various different perspectives.
What, in terms of another sort of innovation sort of portfolio, part of your innovation portfolio, is digital health. And this is, we've touched a lot. Digital health seems to be a very hot topic nowadays on many fronts, and not just in the developed world, but we had a guest on from the Novartis Foundation talking about how some of these new tools extremely useful in not just the communicable but the non-communicable diseases in many developing countries. Talk a little bit about what you're seeing in terms of innovation on the digital health front for sort of the broader WHO mission.
So digital health is obviously, as you say, it's a key element, and I think that there is so much now that is being digitalized and it's going towards that digital sphere. And in fact, the science division has an entire department which is dedicated to digital health and innovation. And I think that signifies the importance that we see across all domains as to how digital health is really coming in and shaping and influencing global health and healthcare. So we work very closely with our colleagues in digital health and innovation. One of the ways that we have a bridge is certainly when we identify, as I mentioned, we have methods to scan the horizon. We use different foresight approaches to think about what might be some possible futures or plausible futures vis-a-vis certain technologies. We organize essentially we elicit expert ideas from various people trying to identify what they think, what they see as technologies that will have the biggest impact. Inevitably, we have the identification of topics and areas around digital health. And whether it goes from obviously what we've seen, the change in telehealth and telemedicine, remote consultations, which we see are becoming increasingly common, to the use of artificial intelligence.
Yep.
We see examples of artificial intelligence is now being used to be able to decipher and read ultrasounds, for example. So artificial intelligence linked to an ultrasound. Obviously, if you're not a specialized technician, the actual result of an ultrasound is not necessarily very clear, but you can have artificial intelligence that can help you interpret that result. We also hear of analysis such as artificial intelligence reading the sound of somebody coughing to be able to identify whether they have tuberculosis or not. So certainly there's a lot of, we see a lot in that sphere, but there are many, many others. So when we identify some of these areas, we do actually interact with our colleagues in digital health, because the question of, well, so what? Now that we've identified maybe a promising technology, how can we think about it? And so our colleagues in the science division, in the digital health and innovation department, are really then thinking about what does introducing digital technology in countries mean? There's a lot of capacity building for countries to be able to make sure that they can capitalize and leverage to the maximum extent possible those benefits around digital health.
Taking now several of these themes that we've touched on, I think one of the places I'd like to go is another paper of yours. This was just published last year in the World Health Organization Bulletin, entitled "Eliminating Mother-to-Child Transmission of HIV, Syphilis, and Hep B in Sub-Saharan Africa." And you introduced the theme here of triple elimination, which is new to us. I've not heard that term before. But again, in this paper, you talk about basically what we've just been talking about: innovation, standards of care, education, or digital health potentially. Sort of wrap up a little bit of what we've been talking about per the WHO Science Division in sort of this example, because I think it really brings it all together into what can really be accomplished with your unit.
Thanks, Sarah. And I think it is an interesting example. And maybe just for context, this is also thinking about how we can use innovation and technology to actually deliver better and smarter healthcare. And in the case of the article that you're citing, this is in the case of what we call triple elimination. So thinking about, obviously, a woman during her pregnancy will be consulting healthcare. Can we take a clinic, antenatal clinic? Can we take advantage of that interaction between the person and the healthcare system, the health system, to be able to maximize what we can test for and what we can think about preventing, at least in terms of maternal transmission. I think what I would take from here and thinking about the work that we're doing is there are a couple of considerations that come to mind. First of all is that clearly technology for the sake of technology is not always helpful. I think that I have come across sometimes innovations or technologies where we think, wow, that's cool. But what's it going to help? Where is it going to make a difference? So just because we can do something from a technological point of view, it doesn't always mean it makes sense. And what we need to do is to try and really identify between huge advances in science and technology. There's something every day. So I think that anybody, even on the mainstream news outlets, you will continuously hear new innovation in various different areas. So how do we actually make sense of it? Not all countries are going to want to incorporate everything, and it doesn't make sense, but some things do make sense. So trying to identify those, I think, is quite difficult. And the wow factor, we have to be careful of this wow factor. Just because we can do it, it doesn't always make sense. So trying to make sense, and sometimes it feels a little bit like walking in the fog and thinking, well, there's a lot happening here, but which are the right ones to focus on? So that would be one consideration. The second consideration, I think, is also trying to think from the context of resource limited settings. And for this, a lot of the work that we do, including in the foresight, including with the science and technology work, is to ensure that we do consult with people who are living and working in various different contexts. And this is really, really important because obviously a certain technology might make a lot of sense in a specific context, but less so in a different one. So I think that we need to keep in mind, first of all, what actually makes sense from a global health point of view. What are the benefits and who would benefit? How is this actually going to make someone's life healthier, easier? The second point would be making sure that we're thinking of both the benefits and the risks. We don't want to be alarmist. We see the benefits in most cases will strongly outweigh the risks, but we do have to think about the two components. And the third element would be around context and making sure the right people are around the table. And although global public health, I think, has made a lot of progress in this area, certainly since I initially started my career, I think that we do continually have to remind ourselves. It is not people sitting in Geneva who hold the absolute knowledge of what is going to make sense in Burkina Faso or in Ecuador or in Bangladesh. Mm-hmm. And we need to make sure that we're getting the right people and we're hearing the right voices. And I think that this is one of the things that certainly I discuss in the context of my team and my unit, is really making sure that this is something which serves a purpose to the people who would ultimately benefit from. And we haven't really spoken about the Science Council, but maybe I can add a word to that because sure. as you said in your very initial introduction, in addition to the head of the Emerging Technologies Research Prioritization and Support Unit, I also serve as the head of the WHO Science Council Secretariat. Yep. So the Science Council was established by our Director General, Dr. Tedros, following the creation of the Science Division. Mm-hmm. It was slightly delayed in its establishment because we were all working madly on COVID-19. And so it was only actually formally established in April 2021. So the council is about a year and a half old now. Okay. And we're very fortunate to have 9 extremely distinguished members, chaired by Professor Harold Varmus, and co-chaired by Dr. Adiba Kamaruzzaman. So we're very fortunate to have this group of 9 distinguished scientists who really help us think about what are some of the priority areas in terms of science and research, and areas in which the WHO should be focusing on and should be paying attention to. It was important to ensure that this group was not only gender balanced, but also geographically diverse. Mm-hmm. And we've had some really helpful discussions because even if it's a very small group, having some people from different areas around the world. So we have members who are from South Africa, from Thailand, from Haiti, from the United States, or from Europe, etc. But being able to help us and also keep us in check. So one of the major projects that the Science Council has undertaken thus far has been on how can we accelerate the effective use of genomics technologies for the benefit of global public health. And so there was a report that was launched this summer that really summarizes the work and the recommendation of the Science Council, who consulted with a large number of people all around the world thinking about what some of these actions can be taken. So we're obviously grateful as well to have this group who helps provide some orientation and steer some of the work that we do.
That's really excellent. Really excellent. And I wanted to ask you one other thing because we talked a lot. You've mentioned sort of the foresight function and looking out and seeing, 5 years, 10 years, what's potentially coming. I'm also a very big fan of looking at the past as well because I've hung around sort of this industry or the sort of life science space for a couple decades myself now, and I see, a lot of things that were done in the past that we either dropped or we've forgotten about. And, I'd love to just now journey back to sort of the beginning where we started with some of your postdoc work because you were focusing 15 or so years ago on this really interesting microenvironment that exists in the early embryo and the ability, it doesn't have embryos don't have all these interferon, you can't use those for antiviral responses. So it has all these other interesting ways to shut viruses down and extinguish them. I was just wondering, as you undertake this foresight function, you think there's a possibility to revisit some of that? Because I think there's a lot of interesting not just antiviral, but the embryo is chock full of interesting regenerative knowledge and other types of, let's say, knowledge, biologic knowledge for potential use in human application. Any interesting things there that you may want to sort of look at again as you undertake sort of the future looking process? Because I think there's a lot of things that we still maybe have left on the bench that we don't always bring forward to translation, but also offer us knowledge.
I think it's a great question. I do think about things like this, and every now and again, obviously this is a specific area that I've since moved on, and I do every now and again, and I think, I wonder what's happening in this field. Researchers working in this area, how far have they gone? What have we learned? And so, obviously, as I suspect is the case with many researchers, we do keep our eye on the scientific literature of what is happening and what is moving in certain areas, and every now and again, I'll do a PubMed to find the latest scientific articles. What I think you have an interesting point, Ira, in that there is a lot of research that is ongoing. And I fully promote a certain freedom in science and researchers being able to investigate specific areas and to do that freely and to give a certain creativity and liberty in the way that scientific research is conducted. But there is also something to say about having a more coordinated approach to make the scientific research as efficient and as effective as possible. So part of what we do also in the unit, but I think this can apply more broadly, is something about research priority setting. So thinking about essentially with the recognition that in most cases, if not all cases, funding for scientific research is going to be limited. So as a scientific community in any given area, and it could be, for example, thinking about the host pathogen interface in the context of in utero transmission of disease, so during pregnancy. To really think globally, what are some of what is our knowledge? What do we know already? And how can we build on it? And what are some of the priority questions? And it's a little bit of a utopic way of thinking, because I think that the current system obviously pushes individual researchers to get as many publications as possible, and that's often how researchers are actually evaluated and they can progress in their career. But it actually does have a negative effect, which means that people will be unintentionally thinking more about publishing and generating knowledge, but less so sometimes in a very concerted and coordinated way. So this can apply also not just by specific areas, but also on a country level, thinking maybe in the context of global health, what are some of the most important research questions that a country sees in their context in terms of needs? So I think it's, as I say, it's a little bit of an open question, and I don't have a solution to it. It's more thinking about, are there ways that maybe we could rethink a little bit the way that scientific research is conducted and the way that researchers are evaluated for the benefit of the actual scientific production and the scientific evidence. There are people thinking about this a lot. A lot of people are actually thinking also specifically in the context of clinical trials.
Yep.
So I think there've been some studies that show that an extraordinarily high percentage of clinical trials don't actually produce meaningful results that can then be used to shift the needle. And so this year at the World Health Assembly, there was a resolution on how WHO can help promote, and member states can promote more efficient way of designing clinical trials. So sometimes that might mean maybe instead of having many smaller clinical trials, maybe there needs to be one larger one, or maybe the design of the clinical trial, the power needs to be adjusted. But I think there is something to say that when there are limited resources, which is certainly the case in our domain, that we have to work smarter and not harder.
Right. Excellent points. Really excellent points. And one last thing while I have you, I mean, I mentioned, a lot of the outreach that you do, the biodiversity conference that you were on that panel. I know you've been involved in some conferences recently that I saw. Anything else coming up for you in the remainder of 2022 as we enter 2023? Talks you're going to be giving, other conferences, places where we can listen to you, maybe meet you. Anything else that I might have missed, please take the floor.
So conferences are now picking up, and travel is picking up as well. So we are back, and I'm now at conferences and participating. One thing that we have coming up, which is not necessarily broadly open in that sense for the general public, but we are organizing with our colleagues in the African region, so our colleagues of the WHO Africa Regional Office, a workshop on precisely this responsible use of life sciences, the shared responsibility, and what that means from a country perspective. So we're really excited to be organizing this with what we call AFRO, so it's the WHO African Regional Office, and our colleagues at Africa CDC, and working with various countries from Sub-Saharan Africa. Sub-Saharan Africa, well, all of the African continent has incredible science and research ongoing. And really, I think that some of the research institutes are excellent quality, and the results that they produce are excellent quality. So we're seeing that fast pace of innovation happening, certainly, and we're working with them to try and think how we can really find ways to tailor a global framework that we have identified for the responsible use of life sciences and adapt it and be able to implement in countries. So that will be towards the end of November. Myself and some of our colleagues from the unit, together from various other, together from AFRA and Africa CDC, will be working on that. So I'm looking forward to be back working with countries.
Outstanding. Really outstanding. It's a fascinating set of programs, and I'm extremely impressed. I really wish you and your team the best with all of these initiatives. Again, for everybody that is going to be listening to this episode across the various podcast networks or watching on our YouTube channel, again, you've been listening to Dr. Anna Laura Ross, Unit Head, Emerging Technologies, Research Prioritization and Support, World Health Organization Science Division. She also heads the World Health Organization Science Council Secretariat. And I want to thank you again for taking the time out of your schedule to come talk to us for a little while about all these topics. Obviously, thank you for everything you've been doing in the biosciences. And as we say on our show, thanks for helping to create a better tomorrow for so many people out there via what you're doing. It's a really very inspiring story.
Thank you. It was a pleasure to have this conversation with you.
Good seeing you.